Hi, this is Dr. Cameron Costa-Seidel. I want to propose a possible theory for COVID-19 physiology, for what we're seeing when we're looking at all these 6 patients and we're trying to figure out what's going on with their lungs. Now, I know a lot of people are saying you shouldn't be throwing theories around and everything like that, except that I have not heard anything, any single physiologic rationale for what is going on right in front of my eyes. I think those of us in New York who are seeing things that we would have thought impossible just 2 months ago are willing to believe something else could possibly be possible. So I just want to talk about what the general physiology is, and this is for medical professionals out there. We don't have the time right now to research this. So for anyone who does, please disprove it or prove it, but let's just try to keep working. We will get to an answer. I can feel it. We're going to get to an answer. All right, so, when we're talking about COVID hypoxemia, generally, there's 2 things which I hear people batting around, Is it a VQ mismatch or is this shunt physiology? And yet, none of them really work very well. Now, I'm talking about the patients before they're intubated, okay? The patient that's sitting there on high flow of 80 or 90%, saturating, 89, asking you for a sandwich, or they don't seem to be hungry, but, who's talking to you, who's not sort of overtly shortness of breath. They go through these cycles of tachypnea and this periodic breathing, but what is going on with them? Because none of it necessarily seems to fit, right? It could be a VQ mismatch. And people are talking about maybe this being a microthrombin disease, all right? This is a simple drawing, but if this is the alveoli and this is the capillary, this is the alveolar capillary interface. And what we're talking about is what is going on here. And we know something is going on here, all right? This is where the carbon dioxide leaves and the O2 comes forward. People are talking about maybe it's microthrombin disease. There is, some evidence of that. And if that's true, if you're building up sort of thrombus here, it is possible that you're having a VQ mismatch, which there are some areas that are ventilated, but you're not having as much perfusion. Yet, from what I'm hearing, if you thought that this was the main process by which this disease was occurring, you would expect increased capillary pressures. And at least we're not seeing that. At least early on, from the reports that we're seeing, that people don't have significantly increased pulmonary pressures or capillary pressures. So I'm not sure that that is it. It generally is not fitting that physiology. The CO2 in most of these patients is pretty low, very low. Now, if you have this, you can correct it with increased ventilation and so forth, but it doesn't seem to fit. And the shunt physiology also doesn't necessarily seem to fit. All right, shunt is where blood is basically moving from the right side to the left side without being oxygenated, which occurs in very bad pneumonia and very bad, ARDS when there's proteinaceous material, something else in there. But this tends to be more recruitable and doesn't tend to respond so well to oxygen. These patients that are on high flow, of 90% are saturating 89. If I take off their oxygen, they're going to desat down to the 20s within minutes. So they are responding to oxygen. And so what I am proposing, and I know some people may think this is just absolutely impossible, again, we are willing to accept the possibility of something new, because what we are staring at in our patients is something we would have considered impossible, all right? Let's say it's not either of these, or maybe it's partly of these, but let's say it is a diffusion problem. And this is something we never see, all right? We don't see a diffusion problem ever, rarely ever in acute conditions, all right? We see them in advanced pulmonary fibrosis and other advanced diseases. But this physiology does seem to work. All right, perhaps the virus is attacking, whether it's the capillary epithelium or the alveolar epithelium, that it's causing edema right here, and it's causing a problem of diffusion of the oxygen. Now, carbon dioxide is about 20 times more diffusible than oxygen, so they're not having problems of diffusing the CO2. But if it does seem to work, if they're having a progressive edematous state of the alveolar capillary complex, it is possible over time, over 5 days, 10 days, 14 days, they're having increasing problems of diffusion. Now, this would have major clinical implications, because what would make this worse? Anything that increased your transit time through these areas. So, tachycardia should then make it worse. Which means that we would be more aggressive with the heart rate. Exercise should make it worse. Anything, again, that increases the transit time. And if this was true, if this was actually true, we can actually change some of our clinical therapies to match this model. And that is what we need. We need a model by which we can then match our therapies. Okay. Furthermore, to take it further, I hear everyone saying, and this is not high altitude pulmonary edema. I never said, and no one is saying that it is high altitude pulmonary edema. My patients are in New York City. All right. We, as far as I know, are right at sea level. We're on the Atlantic Ocean. Okay, so I'm not saying this is high altitude pulmonary edema, but it is sometimes a little shocking. All right, it's a little shocking that we say that humans can have a maladaptive, hypoxemic, pulmonary vasoconstrictive response in some situations, and yet in this situation, they shouldn't have it. Listen, it is possible if this is a progressive diffusion, hypoxemic diffusion problem with dropping PaO2s, okay? The PaO2s, despite supplemental oxygen, are getting worse and worse and worse, then at some point I would expect in humans that you're gonna have the same vasoconstrictive response, which we've already seen from the physiology in patients at high altitude can lead to a maladaptive hypoxemic vasoconstrictive response. And I'm telling you that we are having patients that are dropped off at the door, saturating low. Before we can get them into the resus room, they're going bradycardic, and we are seeing pink frothy sputum coming out of their mouth. And that is just not something, that can be denied. And we've had multiple of those patients, and we are rushing them in, and we are seeing them before we intubate them. We're seeing pink frothy sputum come out that looks exactly like pulmonary edema. So it's just hard for me to believe, for someone to convince me that pulmonary edema is not part of the end stage of this disease. Okay, so I would just like people to think, to open the eyes to the possibility, to prove it or to disprove it, that this could possibly be a problem of progressive hypoxemic diffusion leading to eventually a maladaptive hypoxemic pulmonary vasoconstrictive response leading to regional pulmonary edema, which is then eventually leading to death unless we intervene. And if this is a model that is right, or if it's a model that is possibly even close to right, even half right, a quarter right, this is a model by which we can work with, and then we can develop therapies, and we can try to treat these patients the best that we can, and try to get the best outcomes for them. So I thank you for your time and for listening, and as always, I appreciate any responses. Thank you.